colleagues. Now, here I'm talking about barrister, but he prefers to be called Mr. I'm talking about Mr. Babatunde Irukere. Mr. Irukere, thank you very much for coming on.
Thank you for inviting me.
Director General and Chief Executive Officer
Correct.
of the Consumer Protection Council. Now, you've just launched, well, a document, but actually it's a statement, the Patient's Bill of Rights in Nigeria. Zipped through my memory bank. It's about the first time I've heard of that kind of a thing, the Patient's Bill of Rights. Now, this is not a bill in the sense that it's going forward to a particular house of legislature so that it can become law in the way we understand normally, usually, the word bill. This is a Bill of Rights, which is a document, a statement of all the rights of the Nigerian patient, correct?
That is exactly correct.
So this is, it's like a Magna Carta, a document where this is what you not just deserve as a Nigerian patient, this is what you are entitled to, and it's enshrined in a law somewhere.
That is exactly what the case is. You have captured it absolutely well.
Okay, so this Bill of Rights that we're talking about now, it's not as if anything really new has happened in that sense of new policy. The policy already exists, but might not have been applied to the level that you think the Nigerian consumer, in this case patient, deserves.
That is correct. And like you rightly noted, every single right that is identified in the Bill of Rights already exists in one document or the other, mostly in different pieces of legislation, from the Constitution all the way down to the Consumer Protection Council Act, the Hippocratic Oath, and all the other ethical codes for healthcare workers. But typically, almost every profession concerns themselves with their own professional ethics or their own legislation. And so what this does is to aggregate everything so that it's a document that actually covers every single person in the ecosystem.
Just in trying to understand it, people know that, get hold of it. But the one thing it seems to be emphasizing is the dignity of patients being intact at all times, no matter who that patient is.
That is entirely correct. And the guiding theme that was on our mind was what we would call the 360-degree approach in healthcare, which is, the acronym QED, which is otherwise known as Quod Erat Demonstratum, meaning the totality and the end of everything. And so for us here, it's quality, equity, and dignity, and that's what guided us. And from that theme, which is also consistent with the World Health Organization theme, you would see that all the rights derive from making sure that you're promoting quality, you're promoting equity, and you're promoting the dignity and respect for the patients.
Equity meaning fairness.
Fairness.
You're being fair to the patient.
Yes, so fairness to the patient, fairness in access, a lack of discrimination, so you don't discriminate against people based on their religion, their gender, their age, or even potentially their subjection to the criminal, judicial criminal process.
Or indeed, I imagine it goes without saying, their social status.
Absolutely.
You can't discriminate because, and I wanted to come to that because I know that when we're speaking, you said that look, there are many phases to this. There's the technical aspect, the implementation, and all of that. Because I was going to ask that, as a broad policy, it has been arrived at, the Patient's Bill of Rights has been arrived at after what is referred to as broad collaboration and consensus. So everybody that is concerned with the healthcare delivery system, from surgeons to doctors to nurses to pharmacists to God knows who else, everybody has to be on the same page in terms of the standard required of them.
That is correct. And we had a stakeholder engagement where the Consumer Protection Council reached out to the different organizations, professional associations, and regulators also. I believe we reached out to probably about 250 groups, and every key profession in the healthcare value chain was represented in all the discussions and how we came up and came to a conclusion about what these rights are.
I wonder what you think, Mr. Irukere, how easy the full adoption, such as you in the council will no doubt desire on behalf of the consumer. How easy you think it is going to be to implement? Because you've come in. When you came in, you and your team, you've been working on this. So clearly there was a gap where things weren't the way they should be. Even though nobody was complaining, it's like, well, certainly people like you were complaining because you'd noted it and noted that this is not how it needs to be. But by and large, we were just managing. We're used to being, a bit, imposed upon by people of uniform, ranging from the nurse to the matron to anybody who's wearing a uniform, even out in the society there. So this whole matter about treating a patient with respect and dignity, even when he's not there to really acknowledge the fact that you are so doing. He's out, or the last of his concerns is going to be about his dignity. But somebody is there in those trying times when you're at your most vulnerable. This bill would have it that is watching out for all of that.
And that is the case. And like you rightly said, one of the things that was strongest on my mind is that there is a normal model for consumer protection. And that normal model is to educate the consumer about their rights, and that's the starting point for making sure those rights are respected. And one of the biggest campaigns that I have run since I came to the CPC is a demand and insist campaign, meaning demand for your rights, and as a matter of fact, beyond demanding, insist on your rights. I believe almost half of the abuse can be addressed by people demanding and insisting on their rights, and then regulatory intervention would address the remaining half. But in healthcare, it's slightly different, and that for me was a very big issue. And like I've repeatedly said, I think the most vulnerable point anybody would experience in their lifetime is at a time when they're unwell. And so these are people who are potentially more exposed to abuse or exploitation, and much less are not in a position to demand their rights or even insist. And so in that particular industry, the model needs to change somewhat. It's the care providers who must recognize this right, who must recognize that compassion is not a privilege, and it's not politeness, and it's not a character trait in some or most. It's actually a requirement. It's an obligation in their roles. And so because of that, they must go beyond the normal course to ensure that patients recognize their rights. And even when they don't demand or insist on them, they make sure they defer to them and respect those rights. Only then can we say that there's some level of fairness in the process. And that's really what can balance patient rights with other consumer rights.
And especially as well, the health delivery system that we have, it's not all we would want it to be. Everybody realizes that and understands in part the reason why. The point I'm making is that oftentimes the system is overwhelmed. We just don't have enough of everything, such as we would have. And so when it's not an ideal working scenario condition, you imagine that if a person is not very grounded as a professional on the healthcare side, if he's not grounded in this patient's Bill of Rights, the temptation, I imagine, under those kind of conditions would be very, very high for something to be missed, unless there has been a reset in the mind of our people that, look, yes, you're doing a wonderful thing, you're doing something that is absolutely irreplaceable, but you have to do so according to the best standards, the best practices of mutual respect for human dignity, even though this guy is down. That's going to require a phenomenal mind shift from what I've seen. Are you optimistic that that's not going to be a problem?
I think that challenge exists, but whether we can overcome the challenge is the question. And I really think we can overcome the challenge. The reason is what I have discovered across the board is that both people who should know their rights and those who should respect those rights sometimes are not even knowledgeable about the fact. And beyond being an optimist, my experience is that Nigerians as a people are inherently and fundamentally decent people. And so many times, a good half of us would choose to live by the rules if the rules were clear and transparent and we knew them. I have no doubts in my mind that just an iteration of the rules and the rights and sufficient education to people who work in the healthcare system would by itself, without more, just improve the quality of the patient healthcare provider interactions. Now, even if that's all we achieve, that already moves the needle significantly from where we are. But to address the point you make about whether the situation is overwhelming, I agree. I mean, you said we don't have enough of everything. I don't even think we have enough of anything. And so, but the point that the Consumer Protection Council is making is that in spite of that, in spite of all the challenges, recognizing all these difficulties, the infrastructure deficits, the capacity issues, the disputes, the policy issues, and all the complexities that exist, regardless of that, is there something that doesn't require those complex type solutions that can improve patient care, that can save a life, prevent permanent injury, or promote recovery? Anything that does that to even one is a remarkable success. And so that's why, in spite of all the other challenges, this is a very important initiative. And in any case, if you had the best hospitals, the best 300-bed hospitals, multiple MRI machines, the most skilled doctors and nurses, and all the other healthcare workers in the world, with the best possible health insurance, without the right attitude, we're still significantly behind. So now, that attitude is so fundamental and it's critical. Now, will the capacity issues and all the other overwhelming issues, can they modify even the best of our professionals in the way that they display that attitude? Of course they can. But we must continue to constantly remind ourselves that there's really never a time we're going to have more than enough of anything or everything. But we must continue to give what we can. And I think the rights that are identified, that are itemized by the Patient's Bill of Rights, are such that they do not require any new infrastructure. They do not require any new legislative framework. And they do not require any new professional commitments or ethical obligations. They already exist. And so we can ride on that. We can just simply move to the mindset issue that you raised and just reorient ourselves in how we interact and how we regard people when they come within the healthcare system. And I think with that, we can succeed significantly. Of course, there will be the disparity between those who will do right and those who won't do right. And that's when the enforcement framework should come in, whether it's discipline from the different professions.
Which is a point that the Vice President brought up in his speech, that this is an excellent idea, but what you've just touched on, the enforcement of it is everything, because it's just as well you had said that this was arrived at, this place was arrived at following broad consultation and consensus. So if there are infringements, people just must know that not be play, as we say locally. This one not be play. It is important, Mr. Doctor, Mr. Surgeon, Mr. Nurse, Mr. Matron, Mr. Pharmacist. I'm sorry, you're due for sanction. If that is not done, the Vice President was observing, then it just becomes a beautiful set of words and no more than that.
Very true. But again, you also know that where there's no law, there's no offense. And so for the first time, we're making it abundantly clear to everybody that these are these responsibilities, and everybody has those responsibilities.
And they already exist in laws up and down the body of our laws.
Yes.
Every last thing that is being insisted on by this Patient's Bill of Rights is already, it's not a new thing. The law, the structure, everything, it exists already.
And each of those laws have enforcement mechanisms. The one interesting thing about Section 12 of the Consumer Protection Council Act is that it empowers the council to enforce any enactment whatsoever for the protection of consumers. And so we would use the leverage, that statutory leverage, to ensure that the existing framework in the other places are respected. For instance, what is the record of discipline of nurses by the Nursing and Midwifery Council? What is the record of discipline by the Medical and Dental Council? What is the record of discipline by the Pharmacist Council? And so their consequence management system must become more robust. We're hopeful that this would also create that sensitivity to that issue. And we in the Consumer Protection Council intend to monitor this going forward. We're setting up our own desk for complaints from healthcare facilities so that the piece that is within the Consumer Protection Council's mandate we would address. The piece that is not, we would forward to the healthcare associations or professionals or regulators. And we would continue to encourage them and perhaps sometimes even urge them
And
to ensure that they're doing what they should. For instance, one of the things that I think would help, and I'm looking to have that conversation with the regulators, is that there should be a monthly update. We should know how many people have been reported for disciplinary issues, how many have been disciplined, what type of discipline was it? Was it suspension? Was it a withdrawal of a license? Was it a warning? And we should know. And quite possibly, even if privacy issues preclude the disclosure of identities sometimes, because the disciplinary process sometimes, when there's some negotiation in the disciplinary process and there's supervised release, and sometimes you don't want to disclose the identity. But at least let's know the numbers. And when the identities should be disclosed, for instance, if you withdraw someone's license to practice medicine, it should certainly be published, because people should know that you cannot go to this doctor anymore. And then we're looking to increase the level of responsibility across the board, including even for healthcare insurers, because there's negligent hiring. You must take responsibility for the hospitals you put on your list. If I come to you as a HMO and choose to insure myself and my family with you, and you have a list of doctors that I can go to, if something goes wrong, you have a responsibility there. What kind of due diligence did you do to determine who the doctors that you were aligned to treat your patients or your clients are? And so it is in that moving up the ante in the enforcement mechanisms and the responsibility and accountability framework that I believe the real benefits would be.
Wow. Indeed. It therefore means that this, I keep on going back to the broad collaboration and consensus. Everybody that needs to know about this, nobody can claim ignorance, because in just when you stop speaking now, you had actually touched on quite a wide field as a bunch of professionals and authorities that actually need to come together to achieve these fundamental and basic objectives, which you had earlier expressed somewhere else as, stripping away, distractions, so to speak, for the moment. So we get to the core essence of what this is all about: human dignity when you're at your most vulnerable, because that's the way we look at a person who is ill and cannot necessarily stand up for himself. But at that very point, that's the basis of everything.
And that is correct, because, and that's why, strategically, what we did at the Consumer Protection Council is just to be a catalyst.
Okay.
And we proceeded from a point where there's consensus. I think across the entire board in the healthcare value chain, we all agree that it's about the patient. There's no question about it. It's entirely about the patient. And so let's bring everything about the patient to bear. At least that's one place where everybody agrees.
How did we slip? How did we slip away from this position that people are now seeking to reset us when, and nobody can disagree, really? I don't think any right-thinking member of the society can disagree with this. So what happened? How did we slip away such that such corrective measures are now necessary?
Well, the one thing that I have also found out is that it's easier to be distracted than to focus.
Okay.
And so society, regardless of how egalitarian or advanced the society is, you need to constantly remind yourself about what is most important and to continue to evolve plans and solutions and strategies to make sure you keep focusing on those things that are most important. And society itself is evolving. The whole world is evolving. And so as things change, you must make sure that the core, the core doesn't change, but the methods change with society. And so those are some of the experiences we've had. For instance, everybody gets out of medical school or nursing school or pharmacy school understanding what their role is, understanding why they must defer to patients and respect them. But unless the system continues to make sure that that is the case, it's quite possible for that to be left behind.
Indeed.
And many times
Indeed.
in society, you find that you end up at the place and you're asking yourself the question, I mean, how did we get here in the first place? Because this isn't what this is supposed to be about. And I think what the Patient Bill of Rights does is to actually press that reset button again, saying that, all right, this is a new tool that we can use to find our way back and navigate back to what really is most important.
Healthcare centers, hospitals, take Lagos State, for instance. It's one of the arguably, better systemized in this regard. But still there are issues. For instance, I know they want a one-stop kind of a setup where the patient can be treated by all the professionals right there in the hospital. The pharmacy is right, within reach. You can get all you want from the pharmacy. So it's a holistic kind of a thing. But it doesn't always work like that. Will this whole matter about the quality of services that the patient, gets also affect those kind of areas? And what I meant by it doesn't always work like that is that of the 4 or 5 drugs that the doctor has prescribed, for instance, there might be only 2 available to you in the dispensary. You then have to go buy the others outside, which is a hit and miss kind of a thing. You just hope you're not getting fake, but at least you are sure that the government has all its own screening devices and will not have fake medication within its premises. But now you're laid open. I imagine there will be reasons for it, but do you think this kind of a thing can be mopped up so that the entire protection of the patient that we're talking about can indeed, reasonably be achieved?
Well, I suppose there are different models. A model that you've just described is an integrated model where you have a pretty large or comprehensive apparatus where one facility can address many of the, almost all the issues. And that's a model. But I mean, I suspect only governments can create that type of model right now. Private entities may not be able to create something.
So that might be public healthcare delivery.
Yes, so that might be a public health. And even for the public health, you can have that kind of apparatus and replicate it across the board everywhere. Like if you look at a healthcare system, you've got the primary, you've got the secondary, then you go to the tertiary. So at the primary level, you're not going to have that kind of comprehensive infrastructure that addresses everything. But having said that, though, the regulatory system, whether it's the medicine regulatory system, the standards regulatory system, the professional regulatory system, when all work very well, we won't be too concerned about what model we're running, because whichever way that model is, the checks and balances that should make sure that the quality assurance exists and that not just in the service, but also in the products, the medicines and whatever else, and even in the attitudes would already be operational. And so for us at the Consumer Protection Council, it doesn't matter to us what the model, the operational model is. But what is important is that the key issues, respect for the patients, the professionalism required, the qualifications required, the quality, the equity, and the dignity for patients exists every step of the way.
Where might one, as I imagine many watching and listening to this might say, I think I need to grab a hold of a copy of that Bill of Rights that they were talking about, because it concerns every single person. These are rights that are already enshrined in laws, in the Constitution. You all pull them together to know what you as a patient or anybody in your family has as a right. And the satisfaction here is knowing that the professionals on the other side also know this.
Well, the right would be the rights. The documents, there are 2 documents actually. There's a flyer, there's a short iteration of it that just identifies the rights and one-liner items, the right to information, the right to respect, the right to a clean, safe, and secure environment, and just like that. But then there is now the illustrated guide, which is a several-page document. Yes. And the illustrated guide is it's what I think the professionals would be far more interested in. Because it itemizes each of the rights, it addresses what the responsibilities are under each of those rights, and it also has a patient responsibility. And so I imagine that many service providers would even want to extrapolate sometimes just the provider rights and responsibilities, sometimes just the patient responsibilities for educational purposes. But one of the ways that we're hoping, and the CPC, we did what we could within our budget. We printed several thousand copies as seed.
That always is an issue, isn't it?
It is.
You
It
know,
is. It is.
funds to do the necessary.
Absolutely. And so we printed some seed copies, which were distributed at the launch, and we're still moving out through our distribution channels as we speak.
It's probably available online? Would
Yes,
it be available
yes,
online?
it will be available
At your website?
Certainly, it will be on our website, and we're looking to work with other professional associations to promote it on their websites also, so that their members can have it, at least get it from their association website. But one of the other things we're looking to do is to write guidelines. I mean, CPC, the law empowers the council to write guidelines with respect to issues that affect consumers. And one of the guidelines we're looking to write around this is to ensure that healthcare facilities paste these rights in places where both their employees and patients can read and become familiar with it. And we're also translating it into the 3 major languages and then Pidgin English also.
So the thing is that this Bill of Rights shall be known up and down the land. That is the objective of CPC.
That is certainly our intention.
You know, CPC is the Consumer Protection, Protection Council.
Yes.
Anything that is consumed by the general populace, you're watching out for, for the general populace. So health is just one of the things, but there are many other areas, right? It's not as if this is the entirety of your basket. It's just that this, at the moment, is what you're focusing on. Maybe we'll get a chance to talk about some of those other things, but I'm sure there will be people who will want to call in, and so maybe when we come back from break, we'll see if there are 1 or 2 questions about further expatiation of any aspect of that. But before then, there's the technical aspects to all of this, and that's a much more involved thing, because the technical aspect, what you've helped us with in the past half hour or so is give us an overview of what the intentions are. Now, the next level is the technical aspect of that. What can you tell us about that?
Well, and in some sense, I've spoken a little to the technical aspect, which is, for one, an accountability or consequence management system that would ensure that when there's a violation, that there's a repercussion, whether with respect to a facility, and certainly with respect to individual licensees, or license holders of different professions. The other technical aspect is how to ensure that patients recognize their rights and know when they're not receiving, when they're not being respected. But more importantly, that caregivers, every step of the way, recognize these rights, and not just recognizing the rights, understand what those rights really translate to as a practical matter. And for instance, what does the right to information in a language and manner that a patient understands it, what does it translate to? Exactly what does that mean? It's rather abstract unless you recognize that what it is. And that's why if you look at the document itself, it's relatively interactive in the sense that we've got images and graphics to demonstrate. So for instance, the right to information, the image there is a medical professional sitting with someone, sitting and having a conversation, just like you and I having a conversation, meaning that you really need to defer and take the time to sit
showing the bedside manner of the
and let them know that this is what it is, and then the letter of the illustrated guide clearly states what it is. Let the patient know exactly what they're dealing with. Let them know what the treatment plan is. Let them even advise them of their right to a second opinion. So, the nitty-gritty of it is how it translates in reality, and we've addressed a lot of that.
Yeah. Let me go on a break, and then we'll come back and talk about it some more. Stay with us, please. We'll be right back. Welcome back, and we've been having this conversation with Mr. Babatunde Irukera, who is Director General and CEO of the Consumer Protection Council. And really, it's upon their latest project, if if you want. They've just launched the the Patients' Bill of Rights. It, targets the health sector, and it's all about international best practices, in consonance with human dignity. In fact, I think the Director General has said that one of the indices is that you can look at how people treat their patients in any country and have a very good idea of what that nation thinks about its ordinary people. You used that in the past. We understand, what this is all about. And you were just going into, the CEO of the Consumer Protection Council, and really, it's upon their latest project, if you want. They've just launched the the Patients' Bill of Rights. It, targets the health sector, and it's all about international best practices, in consonance with human dignity. In fact, I think the Director General has said that one of the indices is that you can look at how people treat their patients in any country and have a very good idea of what that nation thinks about its ordinary people. You used that in the past. We understand, what this is all about. And you were just going into, the mechanisms for the technical aspects. But people are in these systems. We've talked about the professionals, the various professionals that have been consulted. Sometimes the system is not all it could be. There are fakes within. There could be fakes within the system, and this could, mess things up, cog up wheels. Apparently, what we're talking about now would take care of that. There might be some old school professionals that do have the skills, but probably are not using it or don't know that they should use it. I can imagine that there's a whole mix of situations in there. No doubt all of this sorting out, because the Bill of Rights is so clear, would it automatically sort it out? Or?
Well, the one thing it does, at a minimum, is that it draws the regulators' attention to practices within their profession. There is no better way to weed out quacks than for the regulatory process to be aggressive. And so for someone who is engaging in an unauthorized practice of medicine, so a complaint filed about his conduct that ultimately gets to the Medical and Dental Council would sooner than later reveal that this person is not even licensed to practice medicine.
Okay.
And so that would assist with eliminating that. And the more quacks know that they're liable to be discovered, then the fewer the quacks we would have. Because what would happen is that we at the Consumer Protection Council will be waiting on the other side. The moment the Medical and Dental Council, or any other council for that matter, declares someone who was engaging in a certain practice as a quack and unauthorized, we're waiting to receive that person on the other side. We want to subject that person to the fullest extent of the law, including prosecution and for something in healthcare, for endangering lives. And so when you start prosecuting people, you're likely to see that you modify the behavior of many. Now then again, that there are people who are otherwise qualified. Like I said at the launch, there are people who are otherwise qualified but fail to live up to the professional standards that are appropriate. And so those people would suffer some other kind of penalty professionally. And I think that those are the key technical ways that we look to address things. And I foresee a situation where within each of the professions where you're required to continue some mandatory training to keep your license, for instance, mandatory continuing medical training. For instance, we as lawyers have what you call your CLE, continuing legal training to MCLE, mandatory continuing legal training to keep your license. And so I would imagine that some of the models of their training would now begin to include what the content of the Patient's Bill of Rights and how it translates and how to practicalize it.
Might this help in the dramatic instances we hear, thankfully few and far between, where a guy who is not a medical doctor has been fooling the system he's working in until something happens? You see these stranger than fiction kind of stories now and again, where a guy has actually taken a whole hospital system. They didn't know he was a doctor. It turns out he was in university with a real doctor at one time. He saw generally how they do it. How you could fool a system. Now, what we're talking about now will probably make the occurrence of that much, much less likely, hopefully.
Oh, absolutely, absolutely. And as terrible as that anecdote that you have just stated is, it's not the worst. It's not the worst. Yes, because here you are. This is someone who really doesn't have the license to practice, but has the skill. Now, that's no excuse. Having the skill, I mean, knowing how to drive without a driver's license doesn't authorize you to drive.
Okay.
And because the whole purpose of being licensed is that you've secured sufficient training for the one time that something might go wrong.
And you're
Now,
responsible to some professional
some
organization.
Yes. But the worst case, which is even more prevalent, are the people who don't even have the skill, don't have the knowledge, just in the neighborhoods delivering babies, conducting surgeries, fixing broken bones and all of that. And they don't even pretend to be doing this based on some homeopathy or some native medicine. They pretend to be legitimate healthcare professionals,
And
whether as nurses or doctors or pharmacists.
And that's where they cross the line as far as the CPC is concerned.
That's where they cross the line.
When you so name yourself, then you're going to be deceiving the public.
It's misleading.
And it's misleading. And the CPC is able to move in.
It's criminal conduct under the Consumer Protection Council Act.
But there are many such traditional healing facilities up and down the land.
And that is recognized. To the extent that health policy, the federal government's health policy, through the Ministry of Health, recognizes traditional medicine. We respect that. What we would have a problem with is if you make misleading statements or advertisement about what your capacity is or what your process is. Again, that would be misleading.
Or what your product can do.
Or what your product can do, certainly.
So
for instance, if you're in
groups.
traditional,
Yes.
if you're in traditional medicine that is recognized and regulated by itself, and then you say that you're a traditional medical doctor, I suppose that's neither here nor there. But if you now put MBBS behind your name, now we have a problem.
Unless he actually does have MBBS.
Unless you really
in
are.
addition.
Well, yes.
Because there are a few
but
doctors like that.
Even that can be misleading.
Okay.
Because if you are a medical doctor by training and qualification, but you choose to practice traditional medicine, that's fine. But if you portray yourself in the practice of that traditional medicine as practicing the orthodox medicine by your appellation or the way you convey what you do, that could be potentially misleading. And we would have a problem with that.
I see. So doctors have to be very careful in that regard. First of all, doctors, apart from, I think I just remember as we're speaking that doctors don't advertise. They actually don't take out ads on themselves. Come and see me, I'm the best doctor around. I don't think they're allowed to do that.
No, they're not.
No, they're not allowed to do that. And so the example I just threw up about a guy who has who indeed is MBBS, but also now, because his mother, for example, might have been a traditional healer, he's aware of all the herbs, he's aware of the whole body of knowledge, but he has gone and studied to become a medical doctor. But he still does know this other stuff. And there are patients that will be persuaded only by the traditional methods or prefer it and say, doctor, keep your needles, keep your can you just recommend some rules? What's that kind of a guy? He has to take one. He can't.
Well, it's not necessarily whether he has to take one or not. So long as the policy and the regulatory process allows him to combine, we don't have a problem with it.
And it's
but there must be full
disclosure.
Okay. I mean, the way we look at anything is, does the patient clearly understand exactly what they're getting into? Okay. And that's our question. And determining that the answer to that question has both objective and subjective standards. There's an objective standard about what you're truly putting out there and disclosing. And then there's a subjective standard of taking the patient as you find them. What did they understand they were doing or getting into? And it is really a test of both that objective and subjective standard that would help us determine if that doctor, for instance, was doing the right thing or the wrong thing.
As you've said earlier, these professional, in the healthcare sector, these professional bodies, for the doctors, the dentists, and just about everybody else. All of those, they have their own system, their own code of ethics, code of conduct, maybe constitution, disciplinary procedures, and all of that. But you're saying that they normally would take up any problem, any problem that came to their attention about malpractice or anything flying in the face of the, the whole way the professional, esteemed profession is set up, they will be able to address that. But in addition, you say you are now watching above that. And so you're observing what they are getting. Because I was going to ask the question, so how do you know if there's an infringement, for instance? It might be easier perhaps to come to the CPC as opposed to maybe being intimidated by a bunch of professionals, and you might be fearful of the so-called esprit de corps effect.
Well, and that's a very tricky question, but the whole space of professional discipline and all of that is not within the mandate of the Consumer Protection Council Act, and rightly so. Professional discipline must stay with the profession. It must be your own peers who recognize and know what the standards are, that can hold you accountable to it and decide what your fate is when you've done wrong. But after professional discipline, if the professional disciplinary process ultimately results in something that demonstrates that this supposed professional has violated the law outside of the ethical code, then of course.
So you'll be watching how the association handles it.
We watch how the regulator handles it and what the outcome is.
Okay.
So for instance, if a doctor was sleeping when he shouldn't have been sleeping, or some other healthcare professional was sleeping at the wheel and it resulted in some level of carelessness, and so the professional association says, well, you're a legitimate doctor, you've made an error here, you're going to be suspended, and that's fine.
That's fine.
That's fine.
Okay.
However, for us, we're looking at how a remedy for whoever's been injured by this.
Okay.
So for instance, if a patient asphyxiated in that period while you were supposed to be watching and you were not watching and that has resulted in injury, we're going to hold you accountable for that injury.
I see.
Whether the facility you work and that doctor individually, and so that's some kind of civil liability.
Indeed. Ebube in Makurdi, good morning.
Yeah, good morning.
Please go ahead.
Yeah, good morning.
Good morning.
Hello. Yeah, good morning. Can you hear me?
Yes, we can hear you. Go ahead with your comment or question.
Okay, thank you very much for giving me the opportunity to contribute to the program.
Sure.
What I want to say is that I have carefully listened to the guest you have in the studio there.
Mm-hmm.
But I actually want to contribute as a Nigerian because I live in Nigeria. His analysis is quite excellent, but the truth is that you cannot actually pinpoint a true reflection of those health policies that he has analyzed over there in the studio. There, you cannot really see a true reflection of it in Nigeria. So my contribution is that I'm actually trying to appeal to the relevant authorities and the body. Let them try so that some of those things they tell us on the media houses, we see the true reflections of those things on ground. Because I am a Nigerian, I live in Nigeria, and I see that some of those things that is being discussed there you cannot pinpoint the true reflection of those things. For example, now you find cases, people are sick, they go to hospital, they don't attend to them well. At the end of the day, they ended up not making it. For example, about 2 weeks ago, I was in a scene where a man, a lecturer came in one of the schools, I don't want to mention names, the man, he is actually, and we rushed him to the hospital, and I tell you, because of delay, and it was an emergency, the delay, we got to the hospital there after about 15-20 minutes, but because of the delays, before a doctor or somebody was sent to him, the man ended up to die. When you come on here, you tell us this kind of things, that those things are practicable, or we see those kind of things. I think it's not really good. So let's try and see how we can improve on those.
Okay, Mr. Ebube, thank you very much.
That's my contribution.
Thank you very much. Thank you very much for calling in, Mr. Ebube. I wanted you to get that. It was a bit lengthy, but I wanted you to get it all in. And it seems that he's a bit apprehensive. I'm choosing the word that I used as to whether these things that they're talking about. He says there's no way you can see a reflection of these very things. Well, I wonder if that is actually the point, that because you don't see it commonly is why we're working on it now.
That's exactly the point. I mean, I understand his cynicism, but I strongly disagree with it. Again, what we're talking about is attitudinal. It's for the most part attitudinal. And again, like I said,
it's like he's given up on us. That look, I'm in Nigeria here. There's much in that statement. I'm in Nigeria here. Just as much as you and I know what goes on, the way our people go about doing what they do.
Yes, and the overwhelming challenge exists, and I understand that. The hospital experience, even the consultation experience, is incredibly difficult. So you have one doctor who's going to end up seeing what? A line of 50 patients in one day, and he's going to, how many hours is he going to work? You have one nurse who is going to do a ward round and has 31 to 35 patients. So those are problems that exist. However, what we still need to mitigate those difficulties by making sure that we approach the interactions in a manner that truly demonstrates quality, equity, and dignity.
Okay.
If we're able to do that, the problems won't go away, but the outcomes would be better.
But that seems to be what Ebube is doubting we're going to be able to pull off.
And that's where I disagree. Okay. I really think we can pull that off.
Okay.
I really think people who study medicine, people who study nursing, people who study pharmacy, people who study laboratory science, medical laboratory science, many of them work in this hospital setting and truly want to help.
Exactly. That's the whole purpose of their going into those professions.
Yes.
Ebuka in Kaduna, thank you for holding on. Good morning.
Good morning. Good morning, Gary.
Good morning, sir. Please go ahead.
Good morning to your guest.
Yes.
It's been a while.
Indeed. Mr. Irugera.
Yes. I want to ask your guest in the studio. You know, it's interesting that the health sector is used as the topic of discourse this morning with respect to the role of CPC, Consumer Protection Council. All right? Now, I want to ask him there. He made mention that there are times that authorized medical personnel make mistakes and they are penalized in accordance. You know, if that's the case, don't you think this penalty stalls the process of learning from mistake and also making professionals want to cover up errors which happens out of their own control, something they cannot control? Now, if there are issues whereby authorized medical personnel or certified medical personnel make mistakes, let's do medical procedures like operation and all, and because they have this code of ethics that will make them be penalized for making such mistakes that might maybe lead to loss of life and all, they want to cover up this act.
Okay.
By any means. And that's false learning process.
Ebuka,
so I want to know the role of CPC with respect to this.
Okay, Ebuka, if I understood you properly, professional misconduct being sanctioned, you have your worries about that.
Yes.
That's what you said. Okay.
If it is sanctioned, right?
Yes.
It leads to there's no further investigation to know why this happened, what happened, and how it can be mitigated.
Okay, let's let Mr. Irukera explain it. Let's let him explain it.
I have another question.
No, there's no time. You use so much time on one question. Please understand. Thank you very much, Ebuka. Okay, his concern that the sword of sanction dangling over the head of any would-be professional misconduct practitioner, he doesn't think it's helpful. What would you say to him?
Well, my question is, just imagine the converse, where there is no consequences for anything anybody does wrong. The way the process works is that there are certain standards. Your training prepares you to live up to those standards. When you do not live up to those standards, there's a manner in which the process would work, depending on exactly what went wrong and what didn't go wrong.
Primarily determined by your own peers.
Determined by the profession itself.
The profession itself.
Yes. And for the injuries that occur, you can't, even if your error results in injury to someone, you can explain injury away on account of error. There must be a remedy for someone who's been injured. There just must be a remedy.
Exactly.
That's also a way to make sure that those injuries don't occur in the future or that those errors don't occur in the future. And professional discipline itself is a standalone mechanism. Making sure that errors don't occur is another process that a facility or a doctor or a profession would address in itself. It's almost like flying. Now, the aircraft, the accident investigation is not punitive. It's not set out to find out who did wrong or to punish anyone for doing wrong. It's set out for us to find out what went wrong and prevent it from happening in the future. However, that does not exonerate the airline from negligence or what they could have done. If, for instance, they hired a pilot who's a known drunk and was fired by another airline, that's negligent hiring. You would deal with the consequences or the repercussions of that conduct.
And take each case
And
by
take
its
each
own,
case by its own.
know.
So discipline in itself does not preempt or does not promote cover-up. As a matter of fact, cover-up itself is another subject of discipline.
Exactly. And there certainly is, I don't think corruption has escaped any particular aspect of our life, of our daily life. We can only, as it were, dam against it.
Yes.
Mukhtar in Kano, good morning, sir.
Yeah, good morning, Mr. Yori. How are you doing?
Very well, thank you. You got a question or comment for Mr. Urukera?
Yes, I have a comment. I have a comment to make because the CPC in most of the states are being appointed by the government, by the ruling government. And most of them are not professionals and are not fully educated. So one must just come to protect consumers. They tend to favor their own people in terms of party politics. So I would urge the DG to please go around the state and see what is happening as far as Consumer Protection Council is concerned. In most of the states, you see that those on the seat are not professional and are not qualified to be there, but because they are political affiliations, they have been appointed there.
Mukhtar, do you have any particular, maybe just one example or instance of what you're talking about?
Yes. I don't want to mention names, but it happens. It happens. We know it. Yes. So if the DG could honestly come and check all these protection councils in most of the states.
All right.
The politicians are there, and they are not professionals, and they cannot be able to handle the complaints very well.
Let's find out how true this is, since we have the chief executive of the Consumer Protection Council with us. You heard his charge.
Yes, and I think that there's an error. The Consumer Protection Council is a parastatal of the federal government. Sadly, we're not in every state. I really think we should be, but there's a capacity issue. So we're only in the zones. So we've got 6 zonal offices. We've got a headquarter office, making 7. And then we have offices, an operational office in Lagos. And recently we opened an operational office in Kano, making 9 offices altogether. And that's really because of how strategic and the numbers of people in Lagos and Kano. But many states do have their own consumer protection committees, consumer protection agencies.
Are they affiliated?
No, they're not affiliated.
They're not?
They're not affiliated.
Okay.
Now, the Consumer Protection Council Act requires for states to, working with the federal government, to create the state committees. And that's what the law says. And so those committees, potentially the committees would be affiliated with the Consumer Protection Council. And the governors do have the prerogative of appointing people onto that committee.
Okay.
But I suspect what he's talking about are consumer protection agencies that are controlled by the states and appointed, the chief executive and all of that are appointed by the states. Okay. And it's, I suppose it's one of those areas where you say there's concurrent jurisdiction. The federal government has jurisdiction and the states have jurisdiction also.
Okay. Mr. Ayodele in K2, good morning. You're the last caller. Go ahead.
Yes, I want to talk according to the program.
Sure. Go ahead, please.
My contribution is a question. Yes. Good morning, sir. Good morning, sir. Your guest just said that the Orthodox doctors are not allowed to advertise themselves, their products. But they allow the herbal medical practitioner.
Did he say? No. Sorry, sir. Sorry, sir. I've been on this program. I don't believe he said anything about that. The only thing we said about advertising is that medical doctors are not allowed to advertise themselves. That's the only thing we said about advertising.
Yes. Yes. I heard that very well, sir. Hello? Hello, sir.
There's too much of a delay. I didn't want to say anything. And unfortunately, because Mr. Ayodele was going to go off on a wrong premise and I had to sort of correct that, we've lost him. I don't know what he was going to say.
But I suspect the point he was trying to make is that why would orthodox medical facilities be allowed to even put out would be precluded from putting out any information about themselves, while non-orthodox ones are able to advertise and all of that?
Ad nauseum. Okay,
So
what would you say about that?
Well, I think it's a regulatory issue. I mean, it's how each of the professions are regulated. And so if professional regulation prohibits advertisement, then you can't. Now, I have a problem with an advertisement, an allowance that allows even unorthodox people to advertise and say all kinds of things and say that one product solves many problems.
I know,
but that's
Regulators
something that
have always been at loggerheads with that kind of a thing. We've completely run out of time now, but I want to thank you very, very much, Mr. Babatunde Irukera, Director General and CEO, Consumer Protection Council, and also congratulate you on this initiative between the Ministry of Health and your council, and we'll keep an eye on it and anything for the improvement of delivery to consumers. Thank you very much for coming on our program.
Thank you.
Indeed. So that's our program. Please join us tomorrow for a fresh edition. I am Iyori Folarin. Bye-bye for now.